Like I said, we are live, so thinking start.
Yeah, so 60, 70 attendees are there. Should we start then?
Yeah, we are
I'll,
already 3 minutes into the system. So
Sure.
I'll start.
no, wait.
Oh, yeah, now. Yes, now I can
Good
hear.
evening, everyone, and welcome to this yet again subsection neuromuscular meeting. And this time we have a session from Goa Medical College. Very interesting session. Our topic is monoclonal gammopathies of undetermined significance. So we have two speakers today, half an hour each, and we have Professor and Head of Department, Goa Medical College, Dr. Teresa Ferreira, and Dr. Sanat Bhatkar, who is a associate professor at Goa Medical College, Department of Neurology. So let's begin, and I hand over the proceedings to Dr. Teresa. Yes, ma'am.
Yeah. Good evening, everyone. We will be presenting two cases. So basically, there are two cases which pertain to neuropathies associated with plasma cell disorders. We have tried our best in investigating these patients, but we would like your inputs in both in whether we still should go a step further. Okay, following the presentation, we would like everybody's inputs on these cases too. So Dr. Sanat will be presenting the first case, and then I will present the second case. And then we can have a discussion at the end. Thank you. Sanat, over to you.
Sanat, I think you are muted.
Sanat, you're not audible, Sanat.
Now I'm audible.
Yeah, perfect.
Okay, fine. I'll just keep the phone here because I've put both the things on. But I can't hear you all very well. But I think you all can hear me properly, right? Fine.
Yeah, very clear.
Okay. Thank you so much to Teresa ma'am, Dr. Vishnu, and everyone in the subsection for giving me the opportunity. As madam said, we'll start off with two cases. This is a case of quadriparesis. Mr. PF, a 52-year-old male, come with progressive weakness of lower limbs, initially distal followed by proximal since February 2024, associated with some numbness of bilateral lower limbs below the knee, again since February or March 2024, and then progressive weakness of upper limbs distal followed by proximal since June 2024. The complaints, everything started from around Jan. He had little lower back pain on and off. On activity, there was no radiation or any postural or diurnal variation, but it was never disabling. He never needed to take any rest or any medications for the same. Since February 2024, he noticed difficulty in raising the left ankle, the left foot while walking, and associated with some slipping of chappals. And over the next month, it gradually progressed to the right ankle. He also started having difficulty in walking in the form of ankle twisting. By May 2024, the lower limb weakness worsened and to involve the intermediate musculature, that there was the quadriceps became weak and there was history of knee buckling, and he started needing to walk with support of one person or with a stick. By June 2024, the weakness progressed to involve the proximal lower limbs, and there was some truncal weakness due to which he had to come out of the bed, turn in bed. He started having difficulty in climbing stairs, coming down, due to which he became wheelchair bound for most of the time and was unable to walk or stand for a long period. Also, by June 2024, upper limb involvement started, that is initially distally from the wrist, which progressed over a month to involve proximal muscles by September 2024. So these were the motor complaints all from around February, maximizing till September. Uh, since March, since March 2024, she also had lower limb numbness and thickened skin sensation of bilateral feet, which gradually over a month progressed up to the hips. There was no difference in hot and cold sensation, no band-like sensation over the abdomen, and whenever until the time when he could walk, there was no unsteadiness of gait per se. It was more of the weakness due to which he was having walking issues. There was no stiffness of limbs, no twitching, no thinning of the limbs significantly, no dysarthria, dysphagia, no neck pain, no respiratory difficulty, no fever, headache, or any vision issues, no other joint pains, no significant loss of weight or appetite, no bowel bladder involvement. So this was the brief history. Just to summarize, it is, looks like in view of the ankle twisting, knee buckling, looks more like a lower motor neuron weakness of the lower limbs, followed by the upper limbs, distal followed by proximal in a relatively quick progression, initially asymmetric for the lower limbs and then symmetrical. Large, as far as sensory involvement, looks to be more of a large fiber involvement with the thickened skin sensation. Uh, Not too much of burning or this temperature differentiation. Also, there was a mild lower backache. So to localize, but lower backache was never very significant. So to localize, I would still consider as my first DD as peripheral nerves, more involving the motor more than sensory, and sensory large fiber. So as motor and sensory large fiber, both I would think more of a demyelinating etiology. Only oddities is for a peripheral nerve is that it's a very rapid progression for a peripheral neuropathy by prototype, and also there's a minimal sensory involvement. Hence, one can't really think of confluent mononeuropathies. But demyelinating peripheral neuropathy would be my first localization. Along with that, as there's a as there was proximal involvement came very fast with the distal, I would also think of the radicals, motor more than sensory. And odd point for the radicals, there was not too much of radicular pain, even cranial nerve involvement and all was not there. So I would still think of a combination of a radical and nerve, like a radiculoneuropathy. So my DDs would either be a peripheral neuropathy with rapid progression demyelinating etiology or a radiculoneuropathy. Coming to examination, high metal functions were normal. The fundus examination revealed papilledema. However, there were no hemorrhages, no other cranial nerve involvement. Neck power was specifically normal. Tone was reduced mainly at the ankles and the wrists. Sensation normal to pain touch initially. Though as it progressed, there was a slight involvement of pain touch impairment below the ankle, but initially it was normal. Vibration joint position impaired in the lower limbs below the knees. There was no sensory level. Deep tendon reflexes were all absent. The plantars were flexor. There was no corticospinal pattern of weakness, and there were no meningeal signs. The power in the shoulder, elbow around 4, elbow 4 minus. Uh, the wrist was 0. Hand grip, small muscles weak. In the hip, there was a slight asymmetry, 4 minus in the right, 3 in the left. Knees around 2, ankles 0. With weak distal small muscles of the lower limbs. So after examination, what is it added to us? They're absent. The reflexes are absent, and that again takes us more in the favor of a radiculoneuropathy. Or the odd thing being absent neck weakness or absent facial weakness. The second, I would still think of a peripheral neuropathy, which is a demyelinating etiology. I would not really think of a cord here because there is nothing, no significant upper limb, no significant UMN involvement which is there. Everything is happening in a length dependent pattern, but faster than normal, and no bladder bowel involvement. So even though there was some back pain, which was not very significant, I would not like to consider a cord in this. Everything looks LMN. Confluent mononeuropathies are very unlikely because the sensory is mainly in a large fiber pattern. It's not in the form of multiple nerves. So radiculoneuropathy versus peripheral demyelinating neuropathies. Possible etiologies, of course, inflammatory, like a CIDP would be one possibility which you would think of first, though there is lack of facial and neck weakness. Pyroproteinemia is another, this because of predominantly large fiber sensory involvement and a rapid progressive demyelinating motor neuropathy. Sarcoidosis, again, though there are lack of cranial nerves, but there is papilledema. So sarcoidosis, pyroproteinemias one can think of. Vasculitis, another possibility, though The sensory is relatively well preserved, but a lot of vascularity like Sjogren's and all can predominantly involve the large fibers with a motor weakness. Paraneoplastic, there's no loss of weight, loss of appetite, but it can always, we'll never leave out paraneoplastic, but it is less likely compared to inflammatory. And chronic infections, HIV, TB, again with papilledema and all, we can never leave out things like TB, HIV, but as there were no prominent systemic features, I would still keep them lower down. So this would be my analysis and my etiological this. So coming to the investigations, the CBC, hemogram, RFT, electrolytes, including calcium, magnesium, phosphates were all within normal limits. CSF was done twice. At first, both the times the proteins were raised, initially 100, then 370. Sugars were normal and there were no cells. ESR also was particularly normal. LDH was normal. There were the CT chest abdomen did not show any obvious organomegaly apart from a mild prostatomegaly, but the PSA was normal and other tumor markers were negative. HIV was negative, sero workup, vasculitic workup, including hepatitis B, hepatitis C, and other ANA ANCA-associated vasculitic workup was negative. Nerve conductions were done twice. Initially, when in the onset of the illness, when only lower limbs were involved, that time when the NCS was done, the motor conduction studies in the lower limb were non-recordable. However, the surals were were stimulable, which again made us think more of a radiculoneuropathy like a SIDP, CIDP kind of pattern. Upper limb conductions were showing a mild demyelinating involvement with prolonged conduction velocity, prolonged distal latencies and F waves, and reduced CVs. The sensory conductions in the upper limb and lower limbs were relatively preserved. So the NCS was showing a mixed demyelinating and axonal, demyelinating more than axonal, I would say, motor predominant polyneuropathy pattern. As the illness progressed in September, when there was a quadriparesis, when we did the NCS, there was a gross change where it showed inexcitable motor and sensory conductions with absent F waves. Everything was non-stimulable. And EMG done also showed polyphasic MUAPs in the upper limbs, lower limbs with incomplete recruitment, suggestive of a neurogenic pattern. There was no spontaneous activity, no fasciculations or fibrillations. So going more into the workup, as you know, today's sessions, when we did an MRI spine as a part of the workup in the initial, when he had come with the initial complaints with lower limb weakness, an MRI was done, of course, because there was an on and off back pain. So there were well circumscribed T2 lesions in the left, in the L3 vertebra with a hyperintense sclerotic limb. Also another lesion in the D9 vertebra and another lesion in the D11. So there were multiple inner lytic but outer sclerotic kind of lesions in the multiple vertebral bodies, and the CT spine at the corresponding cuts also showed sclerotic margins of these lesions. There was no definite soft tissue involvement there, and there were some areas of focal cortical breach also seen. So this is the MRI, the T2 weighted images which are showing the presence of these lesions with a sclerotic rim, inner lytic with an outer sclerotic rim. The T1 weighted images showing the same with a mild enhancement. So the MRI which was done in May later on also showed the similar lesions at D10, L4. There was no worsening, and the CT at the corresponding cut showed lytic appearance with cortical break and sclerotic margins. There was some soft tissue component doubtful at L4, which was into the left psoas. But when we checked, it was not really in a biopsyable or this condition. CT spine in September, which was done, also showing multiple lytic lesions. So these are this is the CT spine, which was done in September. Even in when it was repeated, the findings are similar. So you can see lytic lesions here with the arrows with the sclerotic rim at mainly at D10 and right D10 vertebra, D10, D11, and the left L4 vertebra. There were no cord changes per se, so nothing to explain, nothing in the cord per se to explain the lower limb weakness. So when we see these lytic lesions, automatically we think of paraproteinemia, so we go for the serum electrophoresis. So serum electrophoresis in both were done twice, in fact, once in a private setup and once by us. So there was an M band seen in the gamma globulin region, which was mildly elevated. Rest of it was grossly okay. And so we did an immunofixation. The serum immunofixation showed quantitative M-band present in the IgG for heavy chain IgG as well as a lambda light chain. So there was a clonal hyperproliferation seen for heavy as well as light chain. Both kappa and lambda were abnormally elevated, but lambda was significantly elevated compared to kappa. And in qualitative analysis, it was positive for your IgG and for your lambda. So then we did a bone. So because there was presence of lytic lesions and there was an M-band seen, so we immediately went ahead and did the bone marrow because we started thinking more from a myeloma point of view. But however, the bone marrow was hypercellular, but the plasma cells were normal in number. There were no abnormal cells seen. Particularly, there were no plasma cells abnormal which was seen in the bone marrow aspirate. And a bone marrow biopsy was done, which was also showing which was relatively non-specific. They advised a repeat biopsy, but the patient was a little hesitant. So at that time, we didn't really go ahead for that because for that. But per se, there were no plasma cells in the bone marrow. A PET scan was also done for him because one of the DDs with these lytic lesions and with the prostatomegaly also could be METs. So a PET scan was done which was showing focal lytic lesions at L4 vertebrae, D10 vertebrae, and there was a FDG avid region at the right 7th rib. The arrows are showing the hypermetabolic areas in the PET. So an opinion was taken from interventional radiology regarding the biopsy of this vertebral as well as the rib lesions. However, as both were very close to, I mean, there was high risk of pneumo and this, it was not done in that view. The radiology means they were not very keen for it. So we didn't do it immediately. The fundus, of course, showed papilledema. We got it confirmed from our ophthalmology colleagues, which also showed the same. Hematology opinion was taken. We didn't have an in-house hematologist at that time, so we had taken an opinion from another hospital. So they gave an opinion of a possibility of a plasmacytoma versus a MGUS, and we were told to consider steroid, cyclophosphamide, and bortezomib, but after a tissue diagnosis. So this was all about it. I told you all the history, the summary, the examination, and the investigations which we majorly did. Based on all these, so what all we have in front of us? We had a demyelinating polyneuropathy with a clonal proliferation, that is an M-band positivity with a heavy as well as a light chain, a fundus showing papilledema and sclerotic more than lytic lesions of the vertebrae. No definite evidence of any malignancy found. So we kept a possibility of Poem syndrome as our first DD, especially with the papilledema and the sclerotic lesions. MGUS with CIDP was kept as a possibility, looking at the kind of neurological manifestations he had, and he was quite well preserved. But there were bony lesions, which is very odd for MGUS. When there are bony lesions, one tend to think more of a smoldering multiple myeloma, a progression of an MGUS into a multiple myeloma or a smoldering multiple myeloma. However, plasma cells were also normal, which makes it very unlikely to be a smoldering multiple myeloma, and other CRAB features, that is hypercalcemia, renal involvement, anemia, were not there. So that also was very unlikely to be a multiple myeloma. One more DD which we thought of was a solitary plasmacytoma, but that is odd because as there were multiple lesions plus papilledema and is very unlikely associated with solitary plasmacytomas. A single plasmacytoma can be associated with a neuropathy, but it is much less common as compared to when we think of poems with neuropathies. So our final DD on all this was kept as a Poem syndrome. So after just to go into this, when there was a low limb weakness in May with areflexia and raised CSF proteins, we thought of a CIDP initially and gave a course of IVIG. There was no improvement with IVIG. In fact, he continued to worsen and there was upper limb involvement as well. In September, when he came again to us with the raised CSF proteins, we started on methylprednisolone pulses. He also, as the third pulse was going on, there was no significant improvement. In fact, the patient became a little breathless, and the ABCs were showing a slightly borderline CO2 levels. So we added him on injection cyclophosphamide immediately. We had an option here of going for cyclophosphamide versus rituximab, but in that same period of time, there were a lot of these CIDPs who had come and which were thinking like nodopathies, which had not responded to methylpred and had responded very well to cyclo. So that also tilted our decision. So we ended up giving him cyclophosphamide instead of rituximab, considering an acute nodopathy with worsening. and he stabilized immediately after the first 2 to 3 days after the first cyclo dose. Over the next 3 months, there was a gradual improvement in power noted. However, he developed a steroid-induced diabetes after 4 to 5 months, so the steroids were tapered and stopped, and steroids were stopped around 3 months back. Still, the weakness has continued to improve. He is now only on cyclophosphamide pulses. We give him 750 milligram every monthly. 8 pulses. His 8 pulse was actually received today. Patient is improving significantly. Now we have planned him for a repeat immunofixation electrophoresis because it's been a 1 year interval. And VEGF levels at that time we wanted to do, but they were not being done. Now we have found that it is possible, so we'll be getting it done this time. The CT spine, which has been repeated after 6 doses of cyclophosphamide, was also showing the same lesions. There's no real improvement radiologically. But again, in these cases, we have to look for radiological improvement with PET scan rather than a CT, which helps to tell us the proper activity. The power has significantly improved, shoulder power being 5, elbow 4 plus to 5, wrist is still 2. Hand grip is definitely better than before. Hips are 4 plus, knees asymmetric. The quadriceps are both become 5 now, but the hamstrings are still slightly weak, and ankles continue to remain weak, due to which he is still not able to walk too much without support. He needs support of people to walk. But otherwise, his sensory symptoms have near completely reduced. There's no back pain, and he's quite comfortable otherwise. So coming to poems, it is a paraneoplastic syndrome. The term was coined by Bardwick in 1980. But polyneuropathy, organomegaly, endocrinopathies, myeloma, and skin changes, also called as osteosclerotic myeloma, Takatsuki or Crowe-Fukase syndrome. What differentiates poems from multiple myeloma is that there's a very prominent neuropathy. The endocrine symptoms, volume overload symptoms are there. There's no significant bony pains, no significant renal involvement. The pathology is supposed to be also increased secretion of VEGF, which causes increased hyperproliferation, angiogenic activity. So VEGF levels are high. The lesions are more sclerotic than lytic. The survival is good, and lambda clones predominate here. The diagnostic criteria for Poem syndrome, there are mandatory criteria. It is polyneuropathy, which is demyelinating, and monoclonal plasma cell proliferates, almost always lambda. So both these have to be fulfilled, which was there in our case. Other major criteria of Castleman disease, sclerotic bone lesions, and VEGF elevation. One is required. So we had sclerotic bone lesions in our case. And minor criteria like organomegaly, extravascular volume overload, endocrinopathies, skin changes, and papilledema with thrombocytosis. So papilledema was there. So there was one of the minor criteria also need to be fulfilled. He also had some skin changes, which we noted more later on. There was some areas of hyperpigmentation, acrocyanosis, which were there. So by the criteria, we have 2 mandatory criteria, 1 major, 1 minor, which is, so it was, our case was fitting in the case of poems. This coming to the summary, polyneuropathy, organomegaly, endocrinopathies. Endocrine need not always mean diabetes, thyroid, more about the adrenal, gonadal axis abnormalities, gynecomastia, which are more common. Skin changes like hyperpigmentation, acrocyanosis, hypertrichosis, thickened skin. Papilledema is very common. So even though CIDPs do occur with papilledema, when we think of papilledema, our direction should go thinking towards poems, especially if we have other symptoms associated. Extravascular volume overload. He does have peripheral edema and all, which we initially attributed to the autonomic component of the neuropathy. Bony lesions, thrombocytosis, polycythemia. However, these hematological abnormalities were not there in his case. So what is the workup we should do? A full blood with a peripheral blood film, CBC, RFTs, VEGF levels are very important. We are just sent it today. It costs around 6,400 something. So it is not very expensive. It can be done. Urine analysis, 24-hour urine collection for proteinuria, then the hormone levels, and demonstrating a monoclonal plasma cell disorder by serum urine electrophoresis, fixation, and light chain assay. Bone marrow aspirate, refine biopsy. Ideally, we should have done a biopsy of the lesion that will help to tell us in more continuity whether there is a plasma cell involvement or whether for plasmacytomas or METs. So a lesion biopsy is the most definitive, but we were not able to do it in our case. The NCS, EMG, whole body PET, CT, PFTs, and the echo. So the treatment of poems is without disseminated involvement and with disseminated involvement of the bone marrow. So in cases of disseminated bone marrow, without disseminated bone marrow involvement, if there is a single lesion or very few lesions, then we can just go ahead with radiation. However, in our case, though there was no significant bone marrow involvement, there was a significant plasma cell hyperproliferation there. So in these cases, one can go ahead with a radiation in certain cases. Otherwise, an alkylator-based therapy like melphalan and dexamethasone therapies can be considered, or a high-dose chemo with peripheral autologous stem cell transplant. Because it's the disorder, one of the main prongs of the disorder is a higher activity of VEGF. Anti-VEGF drugs, anti-TNF drugs can be given like lenalidomide, thalidomide, bortezomib. Bortezomib was not specifically given in this case because he had a prominent neuropathy. So that was the reason. Even the hematologist told us to either avoid it or give it in smaller doses. So because he improved with cyclophosphamide, we did not really shift to bortezomib. Though now after his repeat immunofixation, if there is a significant, we'll take an opinion again to decide whether we need to continue with the monthly pulses for a year maybe, and or shift to another alternate regime, especially based on the VEGF levels and all, whether we need to go for bortezomib. The MABs also, the daratumumab is one of the drugs which is known to have some benefit in POEMs. One has to, in these cases, so what we gave basically was the cyclophosphamide dexamethasone therapy, where there is a more than 50% clinical improvement which can be noted. Other regimes are thalidomide, dexmed, lenalidomide, bortezomib, melphalan, radiation, plain steroids, and autologous stem cell transplant. So these are the various treatments for POEM syndrome. So in these cases, one has to always monitor the responses. Responses it's a multi-pronged response. Our patient has improved clinically, but that is not enough. You don't know what's going on inside. So you have to look for the clinical response, the neuropathy response, the hematological response, which is based on our repeating our immunofixation ideally after a year, the VEGF response, so we need a baseline level should be more than 771. So in comparison to that, we have not got the baseline levels, but still now we can at least monitor the responses. If the levels are still coming high, that means definitely we might need to shift our therapy to something higher, and a radiological response which is PET scan based. So there can be in all these there can be a complete response, which is 100% normalization, a partial response, a no response, or a progression. So we always in POEMs after therapy at multiple time intervals of 6 months, 1 year, etc. assess for clinical, neurogenic, hematological, VEGF, and radiological response. Nerve biopsies in comparison to CIDP will show demyelination. However, the large onion bulb pattern might not be seen. Castleman syndrome is a type, can also progress to POEM syndrome. It's a lymphoproliferative disorder, which might have a lymphoid asymptomatic mass or multifocal masses. Sometimes this can also progress into a frank POEM syndrome. These are not up, this is papilledema, these are white nails, and the sclerotic lesions which are seen typically in POEM syndrome. This is the hands of our patient, which there appears to be some amount of pigmentation and of the hands, but we really can't categorize it into anything particular. Just the last slide. So when we think of madam might also be dealing with this, but when we suspect a paraproteinemic neuropathy, if there is a CIDP-like neuropathy, sensory ataxic neuropathy, or a refractory small fiber neuropathy, so then you think of a chronic peripheral neuropathy. Then you see if the M protein is there or not. If the M protein is there, you'll think more of a paraproteinemic with the bone marrow study. And consider multiple myeloma if the plasma cells are more than 10%. If they are less than 10%, then it could be an MGUS or a smoldering myeloma. Smoldering myeloma will not have the CRAB criteria. So if less than 10%, then it will be an MGUS. If more than 10%, it could either be a multiple myeloma or a smoldering myeloma. Smoldering myeloma will not have the CRAB features. Multiple myeloma will have the CRAB features. Demyelinating NCS, so even the nerve conduction, whether it's demyelinating or axonal. So the first nerve conduction becomes very important because the second one was showing everything non-stimulable. So we can't opine on that. Whenever you think of a demyelinating NCS, one has to think of, it could be a plasmacytoma if it's a solitary osseous or an extramedullary lesion. But here there were multiple lesions. If there is things like papilledema, other features, then one has to consider POEMs, especially if there is an IgG and a lambda chain which is prominent. If there is an IgM chain which is prominent, one has to think of MGUS and the DATS phenotype, so and anti-MAG related. So these These are the things we look for in a demyelinating conduction. If there's an axonal conduction, it can think of a amyloidosis, and accordingly one has to work up for end organ involvement for amyloidosis. So to conclude, POEMS is a rare entity. One needs to fulfill criteria to reach the diagnosis. And it's not that we have just ticked the features, so we have got POEMS. We have to still look for in detail whether we can get more criteria to be more sure. It's important to diagnose as a treatment as POEMS from others, as a treatment may be different from other paraproteinemic neuropathies. Sometimes we need overtly aggressive treatment, like many times some studies recommend going for stem cell transplantation in all cases as the first resort. One needs to assess recovery through various parameters and accordingly optimize the treatment regime. And various paraproteinemic neuropathies may overlap. Hence, a holistic approach with a multi-speciality involvement is a key in these cases. Thank you.
Excellent case, Dr. Sanath. Fantastic. Can you take a few questions from the audience? What is the significance of VEGF? Why it is raised in poems?
In POEMS, basically that there is a CD138 clonal cells which are important, and they give rise. So they secrete this VEGF, and there is an increased angiogenic activity, and that is the one which is important. There's an angioproliferation, and because of the new vessels, there's an extravascular leak also, and that is also responsible for all these extravascular features like this volume overload. Even papilledema also is because of this angiogenesis. It's known to contribute towards it. So VEGF is one of the factors which helps to tell, diagnose, and also the severity it helps to tell. Like as the VEGF levels decrease, they suggest that the problem is improving. I'm audible, huh?
Sanath, you are echoing. So can you leave
And
the audio of your computer?
Yeah. Okay, no, now I'm audible, now.
Yeah, sure.
there is one more question. Yeah, very clear. Dr. Sanath, there is one more question. What cyclophosphamide regimen did you pursue?
Okay. Yeah. So cyclophosphamide, we just 750 as per his weight. We gave 750 milligram pulsely dose. So over 2 days, 500 on the first day and 250 on the second day. Actually, because the patient was quite serious on the first day, we gave him a loading dose, not a loading dose. We gave him a dose of 1 gram on the first pulse, and after that monthly pulses of 750 milligrams. And because his responses have been so good, otherwise, normally in most of these other CIDPs or other neuropathies where we give cyclophosphamide, after 6 months, we shift to a oral drug like a mycophenolate or a methotrexate. But in his case, because it is POEMS and his responses have been so good, we have still continued with the same. Every month, he's showing something or the other which is responding. Like today, we see his hamstrings are much better than what they were last month. So that's why we are continuing with the regime.
And Dr. Sanath, there's a question. What is the long-term prognosis of a patient?
POEMS is known to have a relatively. Oh, sorry, I'll put my one phone. It's known to have a relatively better prognosis compared to myeloma and this smoldering myeloma and multiple myeloma. So if treated well adequately, then they can definitely, it has a good prognosis. So one needs to recognize it fast and treat it fast. Especially in this patient, there's not too much of other organ involvement which has come up yet. Diabetes seems to be steroid induced, which is well under control. So in these cases, at least the prognosis seems to be good.
Excellent case. Too good. Vishnu, any?
After a long time, I was doing something non-interventional, so excuse me for any. I tried my best.
No, Sanath, you did well. So it's a few things to poems is always interesting. I mean, Teresa madam will definitely will remember cases that we manage. But in this case, 2-3 things to be showed. It showed some the classical teaching in neuropathies. No, if any demyelinating neuropathy to classical steroids and this one. Think of paraproteinemias and especially poems when you have a severe demyelinating neuropathy which doesn't respond to convention. Usually CIDP will respond at one point of time. It might relapse, but if it is continuously not responding, And here, I mean, I have, Sanat showed an algorithm. I have a little more a simple algorithm for, Sanat's algorithm was little complicated for me. So for me, it is very little more straightforward, complicated. When you have, especially if you have an M protein positive, if it is IgG or IgA. So if it is IgG, IgA, and it is demyelinating, it is poems first. This is what, if everything else first, you come of think of poems first. If it is not poems, then it is CADP unrelated to MCUS. Okay, whether you call it CADP related to MCUS, CADP unrelated to MCUS, whatever you name you call it, it is CADP unrelated to MCUS. But if you have a this one, if you have a mixed picture of axonal or this one, then comes to as Sanat told, it could be vasculitis or if it could be amyloidosis, all those things condition will come. So if you have an IgM, so I mean, I think Madam might be saying about IgM related, so I'm not going to that. It has a different picture. So those two things, if you have a demyelinating neuropathy and IgM, those will clear up initial part of the thing into the picture, initially into the thing. And second thing about some question was about the VEGF. Where does the VEGF come from? VEGF is a very interesting picture. Because I've told, because I presented one CPC in the on Kadilkar sir's one conference. There also I told. So in fact in UK somebody did a study where they told that what is the cost effectiveness you doing VEGF in all CADP patients? Is it worth doing VEGF in all CADP patients to pick up poems very early? Whether rather than so that because there every CIDP receives IVIG. So if you treat unnecessarily IVIG, so they try to look at the cost effectiveness of treating. For example, you imagine a POEM syndrome is diagnosed as CIDP for a 1.5 years and receiving monthly IVIG. So what is the cost of how much money are you saving if you pick up a VEGF pretty early stage? So something of that sort is there. So VEGF both, I mean, it is produced by the clonal cells also, and it causes the angiogenesis, it causes the organomegaly, and it has got a direct correlation with the disease process also. And if anti-VEGF, even anti-VEGF therapies have been tried in POEMS, but even though it may not be the only sole driving factor for in the POEM syndrome. And another question was about the prognosis. The prognosis, there are a lot of people who are, especially in this papilledema. So when we say papilledema in POEMS, actually it's supposed to be considered to be a poor prognosis factor in papilledema. You see papilledema as such because even in CIDP we don't see papilledema in every CIDP, right? If you have a highly inflammation, high amount of inflammation protein reduced of that kind of sort. There are other some risk factors. I think the same paper which Sanath was quoting. So that is a very interesting paper. If you are those who are interested to read, it is there in Annals of in American Journal of Hematology, one update and by Angela Dispensary. That's the paper I always go back. If you want to read about poems, I always go back to the paper. You need everything is there written on that paper. So it has got a risk stratification factors also. Some of them saying of that. So it's a very interesting case. We are always fascinated by POEM syndrome. But I always say my residents also, don't try to treat POEMs alone. Get your hematologist, get your medical oncologist into the picture. Don't be a hero and try to treat POEM syndrome by your own, because it's a proper hematological disease with the neurological manifestations. So let them manage. We should take a little more support. But a lot of neuromuscular expert and neurologists don't agree with me when I say that. But I think for the patient care, it is always better that hematologist treats POEM syndrome primarily. Yeah. Over to you, madam. I think we can go to the second case. We have around 10 minutes over that. So let's go to Dr. Teresa's second case.
Just 1 minute. They
Ma'am, you are not audible. You are muted. I don't know. You're muted. So, just unmute.
Hello,
Yeah,
can you hear me now?
yeah, we
Yeah, I'm
can.
having a problem in just sharing my slides. Just a minute. I'll just do that. One second.
Sure.
Till Madam is uploading the slides, this poem CIDP is often very painful, almost 70% of painful CIDPs. I mean, pain is often a red flag uh, when we see patients of CIDP. Often it points towards poems.
Yeah. And even nerve conduction shows some intermediate slowing. So when you sometimes you see NCV, initial stages.
Axonal features also quite
Yeah,
common.
and sometimes you say the intermediate segments are involved. The conduction velocity is slowed, but distal latency is not that prolonged. So that
Yes.
intermediate segment involvement is more common in poems compared to the classical CIDP. Yes, ma'am, we can see your screen. Yeah.
Okay, so I'll be presenting a case of a 57-year-old. This case, this gentleman presented with I saw him first in February 2024. So he came with a 2-month history of mild numbness in the toes. He's a diabetic for the last 5 years. And on examination, he had, except for a mildly depressed ankle jerk and minimally decreased pinprick sensation in only in the toes, the rest of the neurological examination was normal. Keeping in mind his diabetes, and I did all his routine tests. So leaving aside a glycosylated hemoglobin, which was elevated, the viral markers negative, B12 was normal, and the nerve conduction only showed a mild reduction in amplitude of the bilateral sural nerves. Otherwise, all the conductions were normal. Then about 3 weeks later, he called me up saying that he had suddenly experienced a weakness in the left hand on a Sunday, and he called me up on a Monday morning saying that he had already improved, but he would like to meet me. So when I saw him, on examination, there was just minimal weakness in the interossea of the left hand. Sensory examination of the hand was normal. Reflexes were normal again, and lower limb examination continued just the same as I had seen him 3 weeks before. In fact, when I heard his history, I thought it might be a TIA. So we investigated him in terms of a TIA and asked him to keep a watch on his sugars too. And the MRI came out normal. And after that, he said he continued well after that. He did not have any recurrence. The next I saw him was directly in September 2024. But in between, in July, he was experiencing a weight loss from around November 2023, which continued beyond after he met me. And in July 2024, while investigating the weight loss, they found that he had a very constant transaminitis. The SGOT and PTs used to hover between 60 and 90. And they found that he had chronic liver disease. He had cirrhosis of liver and of non-alcoholic steatohepatitis type. Then in the middle, while he was following up for his liver disease, on the 3rd of September, he experienced an acute abdominal pain. And on ultrasound, they found that there was sludge in the gallbladder, and they made a diagnosis of cholecystitis. He got admitted to hospital on the 5th of September, and he was tried on antibiotics. During this treatment, on the 10th of September, he developed a rash, a palpable purpuric rash on both the lower limbs. And it was seen by, I spoke to the dermatologist who saw him at that time, because till then I was not in the picture. And the dermatologist thought it might be cutaneous small vessel vasculitis. And so he had done a biopsy, which came later, which showed a staining with C3 and fibrinogen. Then the patient flew back to his hepatologist in Hyderabad, and he underwent a laparoscopic cholecystectomy on 17 September 2024. Night before going in for the laparoscopic cholecystectomy, while he was admitted in the ICU, he experienced some odd sensation in his hand, which he could not describe as typically numbness. There was no pain, but there was some abnormal sensation, which he attributed fully to the air-conditioned environment in which he was. Then, following the laparoscopic cholecystectomy, when he came back to his room, he realized that the sensations were not improving, and then is when he started experiencing that definitely that was numbness. And he was discharged on the 20th, and he came back to Goa on the 24th. Now, when I saw him on the 24th, he was conscious oriented. There were no cranial nerve deficits. There was bilateral mild hand grip weakness, but very marked small muscle weakness of both the hands. And there was weakness of the extensor hallucis longus in both the feet, toe grip weakness, which was not there earlier. Reflex examination, his supinator on the right was depressed, bilateral ankle jerks were absent now. Pinprick was very minimally involved over the toes, approximately exactly the same as what I had examined him in February. But this time, vibration, there was early decay over the toes, but Romberg's test was negative. The picture seemed like a asymmetrical type of a neuropathy, but there was no pain. And so then I got a nerve conduction done. Now the nerve conduction showed a very asymmetrical involvement of the nerves, upper limb as well as lower limb, with a lot of nerves non-stimulable, which was earlier stimulable. So the median nerves bilaterally were non-stimulable. The right ulnar was showing the right ulnar nerve showed it was non-stimulable. The left ulnar was showing a conduction block. The lower limb nerves were practically all non-stimulable. So I thought it looked more like to be conducive with a diagnosis of mononeuritis multiplex. But the oddity was that there was no pain. There was no significant pain in this patient. Now, over the next 3 weeks, while we were investigating him, he gradually improved significantly. But he remained with a residual abnormal sensations, decreased sensation in both his palms and both his soles of his feet. But the power significantly improved. Now, in the clinical, looking at the clinical picture, the differential diagnosis that I kept at that time was one, whether it could be an immune-mediated vasculitis or an infective vasculitis or some toxic kind of neuropathy, an inflammatory type of neuropathy, sensory motor demyelinating, because one, there was a conduction block in the ulna. Secondly, the distal latencies in the ulna were significantly prolonged. They were about 5.5. And another thing was infiltration. There was a background, because that is when he told me that he had suffered from a non-Hodgkin lymphoma in 2010. And he was treated, it was a diffuse large B-cell lymphoma, and he was treated with rituximab and steroids. And then he had gone into remission, and then he was doing well. And when I saw that picture where he had seemed to have an asymmetric type of neuropathy with very significant sensory complaints, motor also, but the motor improved, but the sensory remained. And there was no significant pain. I was wondering whether still we could be dealing with some possibility of neurolymphomatosis. And also another differential was whether there was paraneoplastic syndrome. Paraneoplastic syndrome because of his weight loss, which had been happening, but he had already undergone a PET scan by then, and it was negative. Now, investigating him, in his blood counts, there was one point which was significant, is that he had these WBC counts which were on and off low. He had been doing tests recurrently because he had been seeing various hepatologists. And around the time of his cholecystitis, if you see, the count dropped to 2,600. I still don't have a full explanation for this, but this is one point that was there. Following this also, his counts have improved, but the counts always are hovering between 4,000 and 5,500, nothing more than that. His ESRs, which were done on multiple occasions, were normal. The last ESR was 26, slightly elevated. His biochemical investigations were glycosylated hemoglobin was 6.6. Ever since from the month of April, after he had repeated, always his glycosylated hemoglobins were below 7. His liver enzymes elevated like they were from December 2023. GGT also elevated. His AG ratio was still normal. INR was normal. Calcium profile was normal, including the vitamin D. Lipid profiles were normal, and the CRP also was negative. Now, keeping all the differentials in mind, we did a vasculitic workup for any immune-mediated. The ENA was 1+. The ENA blot was, again, showed an anti-SM and anti-RNP, both 1+, mildly elevated. The anchor was negative, PNC anchor. The anti-smooth muscle, anti-mitochondrial, anti-LKM all came negative, keeping the liver in mind. Viral markers were negative. Tumor markers for the CA, CA99, PSA were negative. So then we moved on to do a serum protein electrophoresis because this patient had very significant sensory complaints which were residual. The motor had improved, but the sensory was still quite marked. So the protein electrophoresis showed, although the levels of the gamma globulin were within the normal range, there was an M band seen, as we see here in the electrophoretic pattern. Then investigating further with a serum and urine immunofixation electrophoresis, we found a beta-2 microglobulin which was elevated, IgM which was significantly elevated, and a kappa, free kappa, which was mildly elevated. Now the urine electrophoresis showed a proteinuria, but it was 100% albumin. There were no abnormal light chains in the urine. Now, skeletal workup was negative. Chest X-ray, ultrasound of the abdomen showed volume redistribution and chronic liver disease, and echo was normal. This all was done thinking to look for other involvement of other organs for any infiltrations. Whole body PET scan, which had been done in July, had shown no hypermetabolism in any part of the body. Fundus examination again was normal. There was no evidence of any diabetic retinopathy. To complete his investigations, we did a CSF. The CSF again came normal. The bone marrow, which was aspiration, it showed normal erythroid myeloid, where the plasma cells were mildly increased, about 4%. Megakaryocytes appeared to be normal. Now, thinking of the further differential diagnosis of the infiltrations, we did a nerve biopsy. Now, this nerve biopsy showed an epinural hyalinization with a thickened perineurium. There were marked changes in the myelin. There was moderate to severe non-uniform loss of the myelinated nerve fibers, more in the large than the small fibers. The epineurium showed neovascularization, and there were large and medium-sized epineurial arterioles showing vessel wall thickening. There were some lymphocytes around these vessels. They were negative for lepra bacilli, and the final impression was there was a chronic demyelinating and axonal neuropathy. Now, with this summarizing our patient, we had a patient who had a incipient, slowly developing sensory neuropathy in the background. And over this, he had developed these 2 acute episodes of worsening. And again, with improvement, which was more or less spontaneous, but in the second episode, there were some residual signs which were more than before. Secondly, he had an IgM, which was IgM monoclonal gammopathy, which was positive. He had a beta-2 microglobulin also, which was raised. Bone marrow showed 4% of plasma cells. So these were our points in favor. Now, of suspecting whether, and after ruling out all the other causes of other neuropathies, we kept the possibility of a IgM-related neuropathy. The odd points were we were not fully able to explain a sudden worsening, and we were not able to encompass the chronic liver disease in the same diagnosis because both had come about the same time. Now, looking at serum elevation of monoclonal proteins in the serum protein electrophoresis. Now, many studies have shown that as with increasing age, the incidence of monoclonal gammopathies is increasing. And even normal population above the age of 50 years, the incidence of having a positive monoclonal gammopathy can be up to the tune of around 5% of the population. And this definitely increases. In selected populations of neuropathic patients, of sensory neuropathic patients, that incidence of asymptomatic monoclonal gammopathy can even go up to 10 to 15% in certain studies. So when we have a case, when we do this investigation of a serum protein electrophoresis, it is very important that we exclude all the other causes of a peripheral neuropathy, and the cause should be excluded depending on the pattern of the presentation of the patient and the clinical examination. So if we are not able to find any other valid cause, then we need to pay attention to the monoclonal gammopathy, and then we need to proceed with an immunofixation so that we are able to further categorize. But before that, we also have to look for other involvements like infiltrations as seen in amyloid neuropathies, features of autonomic neuropathy for amyloid. We need to see features for POEM syndrome, as Dr. Sanath has already spoken about. And once we have excluded that category, we come to the category of the elevation of M protein. And then we see whether it is IgM or whether it is an IgG or IgA, that is called the non-IgM. Now, among these, IgM monoclonal gammopathies are far more commonly associated with neuropathies than the non-IgM. So if you take a population of monoclonal gammopathies, 30% of them will be attributable to the IgM. Whereas the non-IgM, the percentage is far less, followed by the IgA will be maybe around 14 to 16%, and the IgG will be about 4 to 6%. So we first need to exclude all the other causes before attributing the cause to the monoclonal gammopathy, and then we need to further categorize the type. Now, in an IgM monoclonal gammopathy, we need to further categorize what are all the possible diseases. So in an IgM elevation, we may be dealing with a clonal proliferation of the type of Waldenstrom macroglobulinemia versus a IgM monoclonal gammopathy by itself. Now, Waldenstrom macroglobulinemia needs very aggressive treatment, as it has got poor prognostic factors, and it has got a multi-organ involvement. So it needs to be treated aggressively. On the other hand, we have the other types of monoclonal gammopathies, which is even associated with IgM, which need to be treated depending on the patient's neurological presentation or if there is any other organ involvement. And the other organs which are also can be involved will be the kidney, and sometimes the skin also can get involved. Now, if we see the IgM-related neuropathies alone, we see that we can further divide them into the anti-MAG neuropathies, which are 55% of them, and the non-MAG, which are anti-ganglioside and other types of antibodies. And less than 4% of them will be IgM amyloid light chain amyloidosis, or IgM associated with cryoglobulinemia, or IgM in the syndrome of Cano-MAD. Now, the red flags, something which points out that it is unlikely. The anti-MAG is normally associated with a chronic, slowly progressive sensory more than motor neuropathy, and it is usually a demyelinating type. The odd points will be if we get an acute onset, a rapid worsening of symptoms, dysautonomia, pain, significant weight loss, cutaneous or central nervous systems. Now, rarely there can be IgM monoclonal gammopathy associated with central nervous system, and that is usually referred to as the Bing-Neal syndrome. Now, coming to our patient, we had certain oddities. We had the sudden worsenings, which again, and also we had done the anti-MAG antibody, and the anti-MAG antibody was negative. So the anti-MAG negativity plus the acute episodes, the weight loss in the background were points which were making us investigate this patient further. Now, in our patient, we ended up giving him intravenous immunoglobulin. We gave him one pulse, after which he's not shown any improvement. Already around 4 weeks have passed, but the patient has not shown any improvement with intravenous immunoglobulin. Now, again, in our patient, we have got a beta-2 microglobulin, which is elevated. We don't have any other features which are suggestive of Waldenstrom's microglobulinemia. So now the question is, my question at the end, which I would like someone to answer, would be, do we consider and do these patients genetic testing, thinking whether the patient may progress to Waldenstrom's microglobulinemia? Or do we progress to treat him like any other IgM monoclonal gammopathy would be treated? So then in a IgM monoclonal gammopathy, which is accumulating more and more neurological deficit, then they need sometimes to be treated with either options will be rituximab or bendamustine with rituximab or a combination of dexamethasone with rituximab. So at the end of this presentation, my differential diagnosis is still an IgM monoclonal gammopathy, but I would like also other views in this of other neurologists in this particular case. Thank you.
Thank you, madam. Interesting case. So what was the nerve conduction study in this? No. This is clearly demyelinating. No, you're muted, I think. I don't know.
It was a demyelinating type. So initially, when the first time we saw him, there was just like a mild reduction in the amplitudes of the sural. So that time there were no features of demyelination. When he had the acute episodes, and then we have followed up after 2 months of that acute episode, we have repeated it again. And now it is still showing demyelination. It shows distal latencies which are prolonged. Some nerves which are non-stimulable are now stimulable, but with conduction blocks and with distal latencies which are prolonged.
So it's clearly an IgM neuropathy, right? So I mean, there is no doubt about it's an IgM neuropathy. Now, when there is an IgM demyelinating neuropathy, there are only 3 or 4 differential diagnoses. One is an anti-MAG, then if it is a like CanoMad kind of picture, whether anti-dialysyl and ganglioside antibody is present, but he doesn't have an ataxia, and I seriously don't think I have a doubt that an entity called CanoMad exists or all. That's also there. Then another thing, if you don't have any anything, if you don't get any anti-MAG, there is a school of thought treat it as IgM gus without any detectable. It's kind of a is called paranodal antibody kind of thing. If you don't detect the antibodies, or it's coming called a seronegative myelitis or seronegative endemo kind of thing, or seronegative myasthenia kind of thing. So if you don't get anything, and then if you have a IgM related clearly classically demyelinating neuropathy, treat it like an anti-MAG, even if the antibodies are negative. So if you don't get, otherwise you work up for Waldenstrom's, or if you get anything else, or any other feature suggestive of anything else. But if it is a clearly IgM and severe demon, I would treat it as something of sort of a seronegative anti-MAG IgM neuropathy kind of thing. Treat it with rituximab, give a trial of rituximab in him. That's what I would like to treat him. But there's no clear-cut thought process in it. But there is another thought process is if it is an antibody negative, and if you treat it as a classically as a CADP unrelated to MGUS, and CADP, but you have classical CADP. If it was a classical CADP, you got some response to IVIG and steroids in that picture. You have not got much treatment response also with that. So I would still, I think if you ask me what I would have done, I would still treat it as like a anti-MAG neuropathy kind of thing. And Dr. Ragesh, what do you think?
I mean, anti-MAG should have a lot of sensory ataxic features.
Yeah, there's a lot of red flags.
Which,
he can stand. He has absolutely a normal Romberg's. Means he doesn't have any ataxia. The man walks. He only complains that his numbness in his palms and his soles. That's it. And he does have a mild reduction in the vibration. And the reflexes which have changed. So when I saw him in February, the reflexes were all normal other than an ankle which was slightly depressed. Now his reflexes in the upper limbs also have gradually depressed. The knee jerk is well present and the ankle jerk is slightly depressed.
So, I mean, last week I saw a case, last 2 weeks back, so a case, somebody made a diagnosis of DADS, so severe distal demyelinating, classical severe demyelinating neuropathy. His IgM is positive. IgM was kind of an IgM MCUS. Now he's waiting for anti-MAG and see his MAG is awaited. So let's see. So he's also walks. He has mainly sensory symptoms, morely distal sensory symptoms. If it was, I mean, there's a controversy in DATs whether you need to treat DATs or not. So that is there. But if you see an IgM MGUS, you can't just leave him like that.
You have to treat it.
Yeah, you have to treat it also. If it is MAG, I would definitely give him rituximab. So if that is, so that MAG will make a difference in the treatment paradigm also.
And this patient also has chronic liver disease in the background.
Yeah.
Now, chronic liver disease can also be, I think, associated with kind of a mononeuritis multiplex like picture. I mean, there is no cause why it should happen, but it is well known that especially I think hepatitis B chronic liver diseases can have a MM-like picture.
Do we have a etiology for CLD here? Or
No, they are put as non-alcoholic. He's been extensively investigated with hepatitis B core antigens and HCV RNAs, and they are all negative. So after that, he's at the moment also, the liver disease is compensated. He's not reached a decompensated state. But that intrigues me because it has happened in the same setting. So I somehow feel that there is a relation between the two. And secondly is that his blood counts is, why did those blood counts suddenly dip at the same time when he had that rash and he had this presentation? So there is this entity of, I have never seen, but of IgM with cryoglobulins and cold agglutinins.
Yeah. So
we are not able to do that antibody.
That usually is axonal or a kind of mixed kind of picture. So usually we don't see a frank demyelination in cryoglobulins. I mean, that's what my literature knowledge says. But you'll have to see. But frank demyelination, I mean, if it's unequivocally demyelinating, usually we don't. I mean, cryoglobulins produces usually a mixed picture or predominantly an axonal picture. So that's something which that also is a good differentials. Second thing is about the CLD picture. CLD can somewhat worsen some in even the MGUS. So those, I mean, if you, I was just Googling how is there a relation between when you sell CLD, and I was also intrigued whether it was there. Some amount of nutrition, this metabolic disturbance, for example, magnesium deficiency and all. So they can actually progress the neuropathy part. So they have some common link factors are there. So CLD making worsening of this, but you couldn't find any direct link between this demyelinating neuropathy and the CLD unless there is a hepatitis B or something which has not been which, I mean, obviously which was extensively evaluated. So if you don't have such an entity, to CLD, it should cause a severe demyelinating neuropathy. I mean, but clinically, patient is other than mild sensory, he didn't have much thing also, no. So there's no much motor weakness at this point.
No, when he had that acute episode, there was a marked motor weakness of the small muscles, and that improved in 3 weeks. The motor part improved. The sensory part, the patient still complained, because even that time when I examined him, pinprick was sensory pain was perfectly normal. It was only the slight proprioceptive impairment in the hands. Okay, it improved.
Age
57.
57.
Yes.
Oh, okay. So why can't it be a simple, I mean, dad's kind of picture? Now it's predominantly sensory. Some motor was there, but it's predominantly sensory.
It was asymmetrical.
Yeah.
So
yes.
MADSEM also, but he never responded to IVIG.
He's not responded, doctor. He's not responded to IVIG. And also another thing is that he has that diffuse large B-cell lymphoma in the background. That is another thing which is also a little concerning, since it is the same. The patient is not very willing to take rituximab because he's already received it, and he had adverse effects with rituximab.
No,
So
even if since he doesn't have much motor symptoms also, so he will be hesitant only. If you mild, actually is not functionally that impaired also, no.
no.
So unless the patient is functionally is very stable, he is most likely to be hesitant to take it also.
Yes.
There are many questions for you, Dr. Teresa.
Yes.
They'll be full of questions. I know.
Full of the cases like that. You can take a few of these.
Anyway, it's kind of interesting, like open cases.
Yeah, it's
Fully
open.
solved cases are little. I mean,
Yes.
open cases. Yes, it stimulates some discussions also.
Okay.
Yeah,
So the
you
first
can
one
choose
is
anyone. Yes.
regarding inexcitable nerve, whether it's called axonal or demyelinating. Now, I think we have a nerve conduction from before, which is normal. And then suddenly the nerve is completely non-stimulable in an acute episode. It is means if especially if the nerve conduction is done quickly, more likely to be a demyelinating. And especially here in this patient, we had a conduction block in one of the nerves, which was clearly, and the latencies were prolonged. So with putting all this together in this patient, I would think it would be a demyelinating more than an axonal. Do you agree with me, Dr.
Yeah,
Vishnu?
I think the question was not in this case. In general, if you don't get any, all nerves are non-stimulable. If an exam, if you give a nerve conduction with everything non-stimulable, and examiner asks you, is it axonal or demyelinating? So that I think that question was in that in that. I mean, I don't know. I don't know
Yes.
what the person who wrote the question, what was in his mind. I somehow think that was in his mind.
Okay.
So.
Sorry.
Yeah. So in that case, if only the proximal stimulation will help some amount of things. Sometimes, especially in hereditary neuropathies and all, if you do a facial stimulation, also sometimes
Facial
you can know it is whether it's a demyelinating or an axonal changes. Yeah.
Okay. The next question is regarding the gallstone. No, there was no gallstone which was found on the gallbladder specimen. It was mostly sludge, but there was inflammation in the gallbladder wall. Uh, The next one is about cryoglobulins. We could not test because we don't have the test here in Goa. And since these are have to be samples have to be maintained at a particular temperature, the patient has to move to another city nearby for them to do it for have a valid test. Why not paraneoplastic? The paraneoplastic is because we actually thought about whether to do paraneoplastic. So we did all his tumor markers. We have done his endoscopies. I have not put up all these reports. Both the upper GI, lower GI endoscopies. His PET CT has been done. So far we have not been able to find any paraneoplastic cause. Even his paraneoplastic antibody panel is which is negatives in serum. When do we think of dads? IgM was positive, anti-MAG. 10%. So if you have so when you have an IgM monoclonal gammopathy and you have a symmetric distal sensory predominantly neuropathy, and you have don't have other signs of a Waldenstrom's to investigate it, and your bone marrow shows less than 10% clonal proliferation, then you will have to think in terms of DADS is one of the would be the differential diagnosis. I cannot understand this question fully though.
No, what they're asking is when do you consider when will you suspect DADS? When you in this case you have a IgM positive, anti-MAG negative with a distal weakness and distal sensory loss, and with the plasma cells also less than 10%. So one question that I asked last time, why not it could be DADS? And Dr. Ragesh has told that it is asymmetric. A lot of other features are there odd for a DADS also because the motor weakness was significant and asymmetrical. That's little odd for a typical DADS. Otherwise, if you look at the patient now with only a mild sensory involvement distally, demyelinating angium, now you might, at this point of time, if you see the patient, you might think of still DADS. But initial part, if you look at the whole course of event, little odd for DADS also.
And that time it was very much pronounced in the upper limbs more than the lower limbs, although so middle-aged man with sensory neuropathy, 8 months, not progressive. Someone has asked here how to approach need of nerve biopsy or how aggressive treatment. So this is not regarding this case, I think. No?
Not this
Yeah,
case.
it's a
In general,
general
you would have asked about.
sensory neuropathy with absent
A sensory
snap.
neuropathy with absent snaps. So if it's a predominantly a sensory neuropathy, after excluding all the more common causes, which will be our diabetes, all the metabolic causes, or deficiencies, vitamin deficiencies, then seeing the viral markers. After that, and of course, depending if there is other systemic features, we have to look for other organomegalies, lymphadenopathies, other associated features. And after excluding a possibility of paraneoplastic, then we have to keep certain specific inflammatory things in mind. So we need to keep, one is, of course, the monoclonal gammopathies. We need to keep differential diagnosis like sarcoidosis, which can present with a sensory type of neuropathy. We need to keep also your our amyloid light chain type of amyloidosis when it is predominantly sensory. So then you would progress with first doing the necessary investigation, which will include, one is, of course, protein electrophoresis. You will have to do a nerve biopsy. And once only you reach a specific diagnosis is when to consider the treatment. Now, when you come to monoclonal gammopathies, the reason to treat also has to be when there is a organ involvement, either the kidney or the nerve is involved. And in neuropathies, whether the neuropathy, how aggressively it is worsening and how much it is disabling the patient. So the reason to treat also will depend on that factor when you're keeping in mind the treatment of MGUS of neurological significance.
So why not this case be amyloidosis? In that case, CLD is due to
So
amyloidosis.
what was odd for amyloidosis was that those episodes that happen suddenly, acute episodes. So that does not happen. Secondly, there was never pain. He's very categorical that even in that there was never pain in those two episodes. It was all like paresthesias, no pain. So, and there's no dysautonomia till now. And it is the nerve conductions again in amyloidosis will show more of axonal. Here you're still dealing with demyelination.
And fat pad biopsy was done?
No, that is in the plan now because since he's not improved, I have already told him. Now, my question was, do we do the genetic mutations to look? Because I've read that the beta-2 microglobulin being elevated is sometimes indicative that that clonal proliferation might get more aggressive and might go towards Waldenstrom's macroglobulinemia. In this particular patient, it might suggest either multiple myeloma or Waldenstrom's. So whether we should consider now keeping in mind those.
I think you should do it because one is an IgM, and second thing is you have beta-2 microglobulin elevated. If it's not that costly or that not infecting, it's worth doing it, I think. And I'm not an expert. You should consider a hematologist or the oncologist are the one who are better equipped to explain. But if you have an unexplained IgM with a beta-2 microglobulin elevated, I think you should consider Waldenstrom's also.
Yeah. So that is our plan now, because he took a long time to decide to start treatment. So now he's taken his IVIG and he's seen that there is no improvement. So now he probably might agree to do the further investigations.
Even cryoglobulins also is equally, if you have a cutaneous vasculitis, somebody has reported, I think Puneet or somebody has asked. So
yes.
Is vasculitis. That is also a strong possibility. But again, my only point against it was the strong demyelinating neuropathy that you see.
Neuropathy.
Is the one. Otherwise, if you have a cutaneous vasculitis, again, cryoglobulin is also a strong possibility. To be honest speaking, I have not yet to see a cryoglobulinic vasculitis or seen or managed. To be honestly speaking, I have not seen. So clinical experience is very less in that case. Yeah. Then there are some other questions. I think 2-3 more questions are there.
Did he receive any immune checkpoint inhibitor? He did receive, no? Did he receive any immune checkpoint?
No, not as yet. Not that he didn't. He only received rituximab. He received steroids, And then he received local radiotherapy since it was a local lesion in the scalp. He had a swelling in the scalp, and that had the biopsy from there came as diffuse large cell lymphoma.
Then there is a question, can this be a paranodopathies?
Yeah, that is the other differential that is
A new kid, that's a
there.
new
So
kid on the block.
so we'll have to, that is another differential that we have to do his antibodies. That
Less
panel.
likely. I mean, seriously speaking, I mean, if you have you
That
have
doesn't
strong
look
clinical
like,
clues. I mean, clinical and laboratory clues of
yeah.
IgM and beta 2 microlone. There's two significant clues are there. So
Unlikely to be
yeah,
paranoid.
unlikely to be.
Fine, I think you have answered most of the questions. Thank you so much, Dr. Teresa.
Yeah.
Thank you very much for having us join this session. It's very interesting. It means many times we are lost in our cases.
Yeah, it is quite
So-
common. It's very common to get lost.
Yeah, it's very interesting. I mean, this unlike other sessions, today's sessions was interesting because
Right.
it was a little thought-provoking. It made us think. And usually, it is a solved case. So
Solved
it's
case already.
because when you have a not a solved case, it makes the discussions and the questions a little more interesting. It's not just the theory that we say about it. No, it was very interesting, and it was good to see fresh faces in the neuromuscular our subsection also.
Yeah.
So thanks for agreeing to be part of it. I mean, at least when me and Dr. Rakesh we took over, one of our mandates that was to spread our neuromuscular subsection to more people across India, so that more people join and present our cases in our webinar. So thanks for joining, and I hope neuromuscular will subsection and more people will join from Goa. Yeah, and you should be a torchbearer of neuromuscular subsection in Goa.
We'll see to it. Yes.
Yeah.
Thank you very much. Thank you, Dr. Rakesh. Thank you.
Thank you so much. Thank you.
Yeah.
Thank you, Dr.
And thank you,
Sanat.
Sanat also. Sanat also did
Thank you,
a
Sanat.
interesting
Very
case.
interesting case.
Yeah.
Thank you. Thank you so much.
Okay.
Bye.
Bye. So next, who is presenting, sir? Next.
And next, I think you have a list now. We'll see.
Yeah, I think Ahmedabad group. Somebody wonder yours.
Yeah. I'll just check with them. Yes.
Yeah. So somebody from Ahmedabad. I mean, one group from Ahmedabad wanted to present. So
Yeah,
we'll let us know. Thank you.
Bye.
Thank you.
Goodbye. Bye.
Bye.